Am I audible? Am I audible?
Yeah, you're audible.
Yes.
Distinguished participant, within a few minutes, we will start our program. Distinguished honorable and respected participant, respected faculties, and the dedicated organizing team, good morning, good evening, Shubha Shandha, Assalamu alaikum. Today, 9th July, Friday, 2021. I'm Dr. Sannat, working as a pediatric hematologist and oncologist in Dhaka Medical College Hospital, Bangladesh. Welcome you all to today's third session in online introductory palliative care course in Bangladesh. This is organized by Two World Cancer Collaboration, the Children's Palliative Care Initiative in Bangladesh, that is CPCIB, and the World Child Cancer, that is WCC. Today, we have two presentations and one Bangla summarization and a discussion. Literally, palliative care refers to a differentiated care approach intended to improve the quality of life of patient with advanced stage disease with no possibility of cure or may complication in cure possibilities and quality of life of the family members through appropriate assessment and the treatment of the pain and other symptoms. A strategy of action such as communication still represent a real challenge for the health professionals. So, effective communication is considered essential for providing integral and humanized care because through it, one can empathically recognize and embrace the patient's need, especially for the children when suffering from cancer. Today, we are delighted to present you the interesting session with communication and breaking bad news in pediatric palliative care. I'd like to introduce our first speaker, Dr. Spandana Rala. Dr. Spandana Rala is a pediatric palliative care specialist and consultant in Hyderabad, India. She works with the Hyderabad Center for Palliative Care, supervising palliative care for children with cancer and other life-limiting conditions across a variety of cities, including in hospitals, at home, or in a local hospice. She has extensive experience in pediatric palliative care and training session, etc. As a trainer with the Indian Academy of Palliative Care, Project ECO, and the Indian Association of Palliative Care. She is going to talk about today communication with the children and families. I'm cordially inviting her to say something in English. Please, Spandana.
Thank you so much, Anna. I'm very happy and privileged to be here. And over the past few years, we have been working on online education through Megan. And I know many of you, and it's great to see you all again. And most of the times I've been in the role of educator, and today I'm here as a speaker, so that's exciting. I'll share my screen, and if you have any questions or if I'm going too fast, too slow, just let me know. I know I have 15 minutes and I'll try to finish in that time, but if I'm exceeding time, again, the slides can be shared widely, and please feel free to interrupt me. So as Janet has pointed out, communication with families is something I think we as pediatricians do very well. But then how do we do it when we see children with serious illnesses and the families are more distressed than usual? It is not a regular pneumonia or a gastroenteritis, but imagine if this is cancer or cerebral palsy with which the child has to live forever. The families are more distressed. So when we are talking about communication here, we are going to concentrate on that aspect. But having said that, there are majority of the principles here that can be practiced in our private practice that we have, and also the regular general pediatrics families that we see. And here is a quote from G.B. Shaw, which says that the single biggest problem in communication is the illusion that it has taken place. How many times have we faced this? We think that we have done the communication well, we have taken the complete history, but then the professor comes to rounds and the family comes up with a complete different story. And there we are shell shocked that this is what I have heard then, but they have changed their story. Maybe sometimes the problem is that we think that we get what they're saying, but we are not doing it completely. Maybe this is something we all have to think about. And this is something I want to start the session with, to think about again, that communication is something we always think that this person is a very good communicator, this doctor speaks very well, or this nurse is very good with children. But we have to remember that these techniques can be learned and they can be taught. So as we learn, so we teach, and we practice and we get better at communication. And also we have to remember it is not just what we say, it's not just the right words, but it is also the right things to say that is important. And the way you say it, that makes the most effect. I'm sorry, just give me a second. I'll mute this. Yeah, thank you. And in effective communication, the most important thing we have to remember is a lot of times we are concentrating on the right words to speak, but we have to remember that they contribute only to 7% according to research, and the tone is 38%, and the body language contributes to the most. So the way you sit, the way you hold yourself, the way you're moving your hands, the expression on your face, everything is communicating even before you do. And I also want you to think about how much time do you listen to your patients and families without interrupting? Do you have a number in your mind? Maybe a 1 minute, 2 minutes, 5 minutes? The research says that the patients are heard only for 11 seconds, and after that we start speaking. So the biggest takeaway point here is sometimes we just have to let the patient speak, if not for the longest time possible, at least to a certain extent, so that we can listen to important concerns. And when coming to communication in children, we have to remember that we as adults speak and also we communicate non-verbally. But in children, it is verbal, non-verbal, and play. Play is something that gives them a lot of control, and a lot of children prefer communicating through play. And there are a lot of myths here that most of the times parents and when not aware, even physicians and nurses, we say that young children don't need to know. This is very difficult news. Please don't tell them. And children can adjust quickly. See, their mother died 2 weeks ago. Now the child is happily going to school. So we think that big changes in life are also easily acceptable for children, whereas we as adults feel a lot of distress. And then we say that, oh, it's a good thing that the cancer happened when the child is 2 years old, because if they're 10 years old, they'll remember everything. They're very lucky that they're too young to understand. And then we also say things like, don't cry in front of your child, or don't tell your child anything, because then the child will start to cry. And whenever we see a child playing, we assume that the child is very happy and has no worries. And children do not worry as much as adults. We think that we as adults are responsible, and that is why we worry so much. Whereas child has no issues and they don't worry at all. And then the easiest of all is children, it's best for them not to know. It's best for them that not to know that they have cancer and it is progressing. So these are the common myths that we have, and this affects our treatments, this affects the way we speak to families, and these are some things we have to think about. And then a common question, especially when you're working with children, people will ask you, oh, you say that you're going to communicate well, then are you going to tell that the child, to the child, that you're going to say that your cancer is progressing and you're going to die? Are you going to disclose death to the child? And here is a small statement, and it says that because children know when they're dying and can sense extraordinary stress. And what they mean is, even though we try to hide the fact from them, children know what is happening in their bodies, and they also see how everyone is quiet around them, how everyone is sad around them, and they understand something bad is happening. And that is why we have to think about telling children in different ways. And there is an interesting survey that was done. And in this survey, 147 parents said that we want to talk to our child about the child's approaching death. And they spoke to the child about it. And 100% of them said that we are happy that we did that. 258 parents did not want to talk to their child about the upcoming prognosis or the worsening of their condition. But what is interesting is not that 100% are happy that they did not speak, 27% were unhappy. So I think as healthcare professionals, we should at least give the parents a choice and explain to them why it is important to speak to a child about impending death. And as you see, a lot of parents will say no, and that is still okay. But having the choice and having the information to understand why it is important is uh, primary for the parents. And most of the time, it is not that the child wants to know, will I die because of it? The child is wondering, did I cause the cancer? I hit my brother that day and my mother said I'm a bad child. So, did that cause cancer? Or I am not praying every night to God and my mother said God will punish me for that. So, did I cause this cancer? Is this why I am stuck in this hospital and not playing with my friends? And then some children worry, can I catch it? In the sense that the patient next to me is breathless. So am I going to become breathless just by being with them or just by playing with them? Can I cure it? They're thinking, is this something that can be taken away from my body completely? And who is going to take care of me? It is during the treatment part. Is my mother going to be here? Is my grandparent going to visit me? Or it can be that what if I'm gone? They might not understand the concept of death. What if I'm gone? Who will take care of me? If it becomes very dark after I die, who is going to be there to protect me? And how will we stay connected? During all these changes, children still want connectedness. If you have seen adolescents, this is much more marked, and because they're very good with sharing it with you will come to know that they're missing their friends, they're missing going out with their friends, they're missing talking to their friends, and they feel isolated. So these are the 5 C's the children want to know usually. And with all the information and the video you have already seen on spikes, how do we even start and where do we even start? It is very simple. You can start by understanding what the child wants to know. And above everything, remember this is not something that has to be done in a one sitting. It is not that I say hi to the child and by the time I say bye, I have to give all the information. It is not that. This is something you can do 5 minutes a day for the next 5 days they are in the hospital, and you can build on that. So just understand what they understand by their illness. And when I say that, most of the times the children say that I have cancer, and you will think that they know what is cancer. And sometimes I have to ask, oh, what do you mean by cancer? And they say it is an infection. So they don't understand that cancer is something that is growing inside them and it is infiltrating all their organs. So sometimes even understanding what the child understands and what they know by what they mean when they say the words. If they say, I'm here to get chemotherapy. Okay, what do you think chemotherapy means? Is something that is important. And all this conversation has to start after building rapport. The child should be on smiling terms with you. You should be on talking terms. And always let the child speak, and then you can go to where the child is leading you. And more than anything, as I said, we have a tendency to interrupt and practice listening to children. And whenever we are speaking to children, we can use drawing, we can use experiments, and always remember the words we use have to be something that they understand. Because when you say you are going to go meet God, they're imagining a huge man or some light and they're going in there. So whatever you're speaking about, the words that you're using, you have to be very, very careful when you're using, so, because they take the literal meanings of it. And children will need multiple explanations, especially when children are playing. We tend to think that after one explanation, they understood everything. That is usually not the case. And they come back for more, and be prepared to answer that. And never lie to a child. I have never lied to a child after learning about communication. I don't tell them anything that I don't believe. And sometimes when I don't know the answers, I say, okay, I don't know this, let me find out and come back to you. And when you have difficult questions, this is something I learned from Megan, and this is very, very helpful. If they say something like, am I going to get better? Or am I going to die? Or am I going to get cured and am I going to be like my friends? These are all very, very difficult questions. You can start by asking, oh, that is a tough question. Why are you asking it? Or what do you think? Do you think you're going to get better? That kind of thing. What do you think? I can tell that you have been thinking about it. What do you think? What are you worried about? And these are some things you can think more about. I think I'm at the end of 15 minutes, and I'll stop here. The slides can be shared and you can go through them for more practice sentences. Megan, do you think that's okay? Or Janet?
Yeah, that's great. Thank you so much, Spandana. We'll definitely share the rest of your slides. This way we'll have time for questions and a bit of discussion after a case presentation.
Megan, after case presentation, discussion will continue. Okay. Discussion after case presentation. Hello?
Whatever we're supposed to do is supposed to go ahead with the normal schedule.
So, thanks a lot, Dr. Spandana, for a nice elaboration. We will go for discussion after the case presentation session. Actually, good communication reduces the uncertainty, anxiety, builds trust, and ensure a collaborative process of care. Helps to explore concern, both expressed and unexpressed emotion, and improve the satisfaction with care. Now we are in a very intriguing session, that is the case presentation session. I'm cordially requesting our respected Madam, Dr. Nilufa Choudhury. She has done his basic certificate course in palliative care from Hyderabad, MNG Hospital in 2016. Since then, various training program workshop that is conducted in pediatric palliative care, related to pediatric palliative care in Dhaka Shishu Hospital. She actively participated all the events. And she has also completed the fellowship in palliative care in 2020 from IPM Kerala. And now in Dhaka Shishu Hospital, different palliative ward was built in probably 2020 March, where she is working and still now. She has several research work in the field of pediatric palliative care and pediatric oncology. Now she is working in the Department of Pediatric Hematology and Oncology ward, and also Pediatric Palliative Care Unit in Dhaka Shishu Hospital. Now, humbly requesting her to conduct the session. Please.
Thank you, Dr. Mega and Dr. Jannat. Hello, everybody. Assalamu alaikum. I'm going to present case regarding communication skill, especially breaking bad news to the parents about the child, and I'm sharing my screen.
Do you want me to share it or you want to share, Dr. Nilufa?
No, okay, I'll share.
Okay. Go ahead.
Main concerns for discussion today: how to communicate with parents when child's condition is relapsed, how to address child's concern when child does not understand the diagnosis and prognosis. A 6-year-old child, let's assume the child's name is Neha, inoculation of the right eye several months ago at another hospital. Family was advised for chemotherapy at that time, but they could not afford to travel to the capital city for treatment. Presented to the emergency department with evidence of tumor progression in the right orbit, abdominal swelling, severely malnourished, limitation of the mouth opening with foul breath and difficulty in swallowing. So the diagnosis was the retinoblastoma. Mother and father are with her today. Father also had 2 older daughters, 18 and 12 years old. Father is a farmer, mother is housewife. Parents have sold their land and spent all their money to get the surgery. The child studied in the 1st grade, stopped going to school 1 year back after diagnosis. Child does not know much about the illness, but she is aware that her abdomen is gradually swollen day by day. She is concerned about her parents because they are worried, crying most of the time. She gets anxious whenever she sees her parents crying. She feels better when she's playing with her friends. Regarding palliative care perspectives, this is an advanced cancer. There's no chance of cure. This news need to be provided to family in a compassionate way. Then how we will tell them the news? We should outline the steps, what we think before seeing them, and review the way what we'll discuss the results with them and the rest of the family. We can use the models, spikes, the setup, perception, invitation, knowledge, emotion, and summary. Regarding setup, there is important consideration here that we should ensure the private room or quiet area, and where there's no interruption or occur, and there also should be a seating arrangement. And we'll invite the counselors, psychologists, and nurse to join with us and ensure palliative care team, if present, team should be present if available, and also invite both for father and mother and also other family member if they wish. Then at first we will regarding our perspectives, we will give them warm reception. We can say assalamu alaikum, hello, how are you? Then we'll introduce myself and other palliative care team to them, and then ask them to tell about themselves and ask them the relation with the children. And regarding perception, to understand the perception of the parents, we have to listen with patience of them, and we can ask them that what have the doctors told you about Neha's condition? What is your understanding why Neha is sick? Here is active listening is very much important in this situation. And before going to giving any information, we'll take enough preparation before giving any information. Before giving any bad news, we'll give some hints beforehand. And in that case, I will give the bad news part by part. And we should be clear and honest. Information should be provided and should use here the simple language, avoid the jargon words, the jargon medical terms, so the parents can understand it properly. And so we can start with this, like that. I'm sorry to say that I have some bad news. The tumor of your daughter's eye has come back after the surgery, and this is a cancer, and it cannot be fixed with medication. And we can invite them that, and we can understood their perception. We can also ask them that, can I tell you more about what is happening? After that, after knowing this, there should be an outburst of the emotion like anger, crying. In this situation, silence and touch is very much important, and active listening also. And we should allow them to say, and we are agreeing to that what they are saying by nodding head or by simple touching. And we can also we can use here the nurse model. We can name the emotion. We can say that I can see that you are feeling very angry. I expect most people would feel that way. In this situation, you have shown remarkable courage. We'll support you through this. And to explore this, we can say, tell me more about how you are feeling. So to check overall understanding, we can say that, do you have any questions? And we have reviewed the plan for the next steps and document in the file so that other palliative care team member can understand that what has been discussed. And we also summarize and we will give the parents the summary and the steps of the suggestion for the child's management. We can say that we cannot cure the disease, but we can give comfort by reducing pain, give nutritional support, blood transfusion. We can give mental support with psychological support to play with the child. And also there is an option we can tell to the child in this case, because cosmetic rehabilitation to the parents should allow by an integral part of the treatment. Which helps in the reintegration in the society. A multidisciplinary approach, including ophthalmologists, psychotherapists, and prosthodontics, was adopted to meet her physical, psychological, functional, emotional, social, and cosmetic demands. And ocular prosthesis is a highly positive and non-invasive approach to improve the cosmetic appearance and psychological well-being of the patients. We can give them the option of this treatment. After parents are made aware about the prognosis, they have difficulty in accepting that there is no more treatment available to cure his child illness. So we should ensure multiple counseling of the parents by psychologists or other team members of the palliative care team. So if we do this, after several weeks, we can see that parents were in acceptance after repeated counseling session. Palliative care team can understand the child concerns using art therapy. Regarding communication with the child, using drawing and toys, palliative care team psychologists to understand the child's concern and address few of them to understand the nature of his disease and why he required the repeated blood transfusion and why these procedures are going through. And we can also involve the child's school friends, school teachers, neighbors, and family members whom they like most in this participation. And we also ensure the parents that palliative care team are always with them, and they regularly contacted with them over the telephone or home visit, or if they wish, they can come to the hospital at any time. And we will give the supportive and symptomatic treatment to the patients to reduce her pain and we'll try to give him comfort and happiness. So thank you all. Thank you very much. If you have any question, we can ask, please.
Thank you, Dr. Nirufa, for the remarkable speech. Now it's a question answer and discussion session.
So I see that there was a question in the chat about collusion. So Dr. Norma said, how do you handle parents who actually request that the true condition of their adolescent child not be revealed to them? And I see Dr. Spandana has written a small answer, but maybe do you want to say your answer, Spandana, and give a bit more about what you would do in such a situation?
It is a fairly common thing that happens, I think, especially in our cultures, and irrespective, I think that happens in the West too, Megan. Parents want to protect their children even though they're 14, 15, 16, and they don't want them to know what is happening. And this is called collusion, where the doctor and the family or the doctor and the patient say that no one else should know what is happening. And there is a term called breaking collusion in palliative care. And when we say breaking collusion, it is not as if one time we say something and the family gets convinced. No matter how good a communicator you are, it might not be possible. And we have to know that even before we sit for the conversation. And you're going to have a lot of resistance because, as you can imagine, parents are very, very worried and they would have had several interactions with healthcare professionals, not many of them very understanding. So probably someone said, your child is going to die, forget your child. So they would have heard things like that, and they would imagine that you will go to the child and say that you are going to die. So that is what they imagine in their mind when you say that, tell the child this is going to happen. So there is a lot of negotiation, bargaining that we have to do. And this bargaining would be, the first question would be, why do you not want your child to know what is happening? And usually the questions would be, he will get depressed, he will die now itself, his heart will break, and things like that. And especially with adolescents, I use a question that, especially when I have a good rapport with the child, I say, oh, but Anil is a very bright child. And the mother agrees, yes, yes, he is very bright. And he knows about what's happening. Mother says, yes, whenever the biopsy comes, he opens Google and he searches everything. Oh, then he must know that the cancer came back. Yeah, he already searched that. So when you start speaking to the mother as expressing that you're on their side, they tell you what is happening. Then I say, oh, if he already knows, do we want to talk more about it with him? Then they're like, no, no, don't talk. And sometimes I also use the strategy where I say that when you're sad, whom do you talk to? And they say, I call my mother and speak, or my husband is here, I talk to him. Oh, that should be very good having that kind of support. And they say, yes. And then I say, oh, I wonder whom he's sharing all his troubles with. Whom does he talk to? Does he talk to you? And as we already spoke, children are very protective of their parents. They say that no, they don't tell me, he doesn't talk to me or she doesn't tell me what is happening in their mind. And then I say, oh, that would be so good for them to have someone to share their worries with. So as you see, there are different strategies you can use. One is where you tell them why you are, even explore why they are not sharing. The other is creating some empathy in the mother and the father about how it would feel to have someone to share their worries with. So this kind of negotiations, sometimes some parents get convinced in one sitting. Some parents would also require 3 to 5 sometimes, but also sometimes when parents are very, very scared, I tell them, did I tell you that your son is going to die? Did I use that word? They'll say no, because I haven't used it, but I've told them in a very soft way. So I tell them that I'm not going to tell him that. And I'm going to tell it to him in a very gentle way. And also remember, if they see you interacting with them for the past few months, that is why we say palliative care should get involved earlier. And if the child and you have a good rapport, they are much more open to it. And having said all this, there are families who will say no to you. And then I negotiate saying, I will not talk about that. I will not speak anything about it. But can I say words like, what are his worries? What are his fears? What are his hopes? I know that's a long answer for a short question, but these are some things that I use practically every day, and most of the times I get good answers.
Thank you. I think those are really good examples of ways that we can break the barriers with the parents. But definitely emphasis, as you're saying, on first meeting with the parents separately. I think that was a question in the chat, is do we talk in front of the child? And we don't recommend talking in front of the child, especially young children, to the parents, because it's going to make the child more upset and more anxious, because it's adult level knowledge, right? The way you're going to tell the parents is different from how you talk to children. And so we don't want to make the child very upset. In the case Dr. Nilafar presented, the child was upset because the parents were crying in front of the child, right? That's upsetting for young children. So we need to create an environment that's supporting the child. and it's not supportive if they see the parents crying all the time. I mean, it's okay. The parents can say, I'm crying because I'm sad, because it's difficult, you're sick, there's a lot going on. But the parents shouldn't be continually crying in front of the child. It will not help. I see another question from Dr. Nusrat. How many sittings do you usually need to break the bad news to them? Are adolescents more vulnerable to those talks? Do you want to just explain your question a little bit, Nusrat? Can you unmute and just kind of explain what you're wanting us to say, tell about?
Hello. Usually, I want to know that the smaller the children, younger, are they less vulnerable, or the adolescents were more emotional, or they're actually knowing the situation about their parents, of the monetary condition, and they think more about the life after death. Are they more vulnerable?
Okay, so are adolescents more vulnerable or young children more vulnerable? I think that's a good question. Maybe some of our faculty, does anyone want to say about different ages and how children are reacting at different ages? Or Spandana, do you want to give any comments on that?
I just want to say adolescents' grief, which comes from hearing all this news, the sadness that they carry in their heart, is much more deeper in my experience. I think sometimes it's because they have been planning their life ahead, and there is a loss of the role they have. Some of the children shared that they wanted to take good care of their parents, they want to study well, want to get a job. Now all of that is gone because of the cancer. They worry a lot about their family, what is happening. And they also worry about the financial stress. Oh, my mother spent 5 lakhs on this treatment, hoping that I'll get cured. Now she's in debt, and if I die, who will clear the debt? So their grief is not mostly about them, but what I've seen is they worry a lot more about their families. And sometimes it's the body image. Even before they die, they start looking different. They have a tumor on their scalp. They start looking, they have to cover it. They feel very bad moving around. So when you say that you can no longer take away the tumor on the scalp, the way they receive it is much worse than in the beginning stages of the disease. So adolescence, it's more complicated. But children also experience it in the same way, but I think they have different mechanisms to deal with play and such. But adolescents are more philosophical. Why is this happening to me kind of questions. And that makes it very difficult for us as healthcare professionals.
Thank you. Yeah, so good points there. You know, there's a lot more that adolescents will worry about. Young children, like their worries are going to be, they're going to have worries, but they're going to be more simple worries. Like they're worried, who's going to take care of me? And will I be able to be at home with my parents and the people that love me, right? It's usually more simple, like they don't like hospitals, and they don't like being away from people who love them. And if you can reassure them, you can be at home, your mom will be with you, your father will be with you, you know, we will make sure that you feel good, like that you'll have medicine so you don't have pain, you don't hurt, then that is pretty reassuring for young children. And when I say young, I say like, you know, under 10. Their worries are going to be less complicated. And they have, like Spandana is saying, the coping mechanism of play. So they can kind of enter into this imaginary world where everything is good, where they're in control, and they can create a very happy place. And they sort of forget about the real world when they're playing, right? You know, they can be so absorbed in that play, and that's very therapeutic. So encouraging play is important. Hospitals often are not good places for children to play because they're very stressful. They don't have many toys. Child is confined to their bed. So that's why we emphasize a lot on play, because it's extremely psychologically therapeutic for children. And when they go home, to encourage the mothers to allow the children to play, and like to say play is going to be good for him. Those would be some things there. Okay, we've got other great questions in the chat. I'm going to read out a few more of them. So from Dr. Mehrab, as the family had already spent a lot of money for their child, then after getting the sad news of cancer, which is not curable, how far the family will go for palliative, which needs economical support? What will be our approach? Do you want to just explain your idea, Dr. Mehrab, in a little more detail? What are you thinking with your question from the case? We'd just like to hear from you.
Yeah, thank you, everyone. As our clinical scenario, the patient spent a lot for the treatment of their baby, but when we'll break the news that the child has retinoblastoma, which is not curable, and we are breaking the news that she will not get well, and for the palliative care, we are planning for palliative care, and this time will take for the palliative care, and the cost of the palliative care, as can the family spend after getting this news, and
That's
what how will we approach, and these are the economical cost you are again sending, but there will be no result, only for just palliative care.
Yeah, so really good question. So, there was kind of, you could see that if they spent all the money for the surgery for the eye and hopefully the chemotherapy, that the child would be cured. And so the money would be spent, for that reason. And now the child's not going to be cured. So do they have any money left to spend to make sure the child has palliative care? So the good news is palliative care is very affordable, doesn't cost a lot of money. We can do, with very few medicines that are not that expensive, we can do a lot to make sure the child has good symptom control and good quality of life. We can advise for the child to be at home, right? So they don't have to be in the hospital, that's much cheaper. And then we can just send them home with some key medicines like pain medication, medication for vomiting, oral medications. And those medications would be very affordable. And if the patient can't afford it, remember that most of our palliative care programs have support for patients who have no money, and they will not charge the patient anything for the medicines, and they will find a way for the patient to get the medicines with no money. So I think most palliative care programs, and those in DACA, are really making sure that nobody takes on more debt by going into palliative care. Any comments from our team in DACA where there is palliative care? How are you helping the patients who don't have any financial resources to get palliative care?
In our hospital, in Dhaka Shishu Hospital, we provide the palliative care support. We have some poor fund, and we also have in our department, and also have a fund from the hospital, and we supplies the key medicines, the painkillers, and sometimes we also give some money 2 or 3 months later to the patients, to the parents for the patients. And we contacted with them regularly over telephone, but we have not yet started the home visit. That is very essential, but hopefully we will start it soon. And like this, we help them properly. And when they used to come, they can come to the hospital anytime.
Thank you. So giving poor people free medicines is good. Yeah, Janet.
I want to add something actually with need for Rappa. Similar experience in Dhaka Medical College also. We have a separate pediatric palliative care unit under the supervision and direction of Professor Zuhura Jamila Khan Madam, and also outdoor unit. And we are supported by different donor organization and individual support also. From medical professional, health professional, and non-medical person, different volunteer organization also, we are getting support that is for monitoring and even advice related. And also we are getting support from sometimes we are getting great support from WCC, that is World Child Cancer also, and other different organizations, those who are working with palliative care, they are also supporting us also, actually. But like Shishu Hospital, we still couldn't arrange the home care visit. Actually, this is important, but we already started telecommunication in this pandemic period. Actually, this pandemic period is a big challenge nowadays for us. Thank you.
Good. So I think that both of you have highlighted one very important point, which is that if you send the patients home, you have to have some kind of telephone service. They can't manage with nothing. They have to be able to reach somebody who can give them some palliative care advice. So either that's your palliative care team at your hospital, or you have to find somebody who can give that advice, because they can't go with nothing. They don't know when to give the medicines. Even if you counsel them very nicely, okay, this pill you take for pain, this pill you give him if he's having nausea, they're too scared to do all of this by themselves at home. So they need your guidance. So that's very important, to have some kind of 24-hour telephone service. And you don't have to worry. They don't call you that much. It's not like they're going to call you 25 times. They're very good. They just call when they need you. So I want to emphasize that we've been doing this for many years, and we don't get too many calls that it's impossible to manage. And I know, Spandana, you guys have a telephone service also. Do you want to say anything about your telephone service? Who manages it?
I think just like how a lot of patients come to Dhaka and then go back to rural areas around it, or sometimes very, very far, it is the same here at Hyderabad. And we realize that we need to have a telephone service, as Megan says. And a lot of time parents are very tired with all the chemotherapy and radiation. And the moment you say it is no more curative, they are like, we are tired, we just want to go home. And we want to make sure that they have someone they can reach out to, and that is the palliative care team. We give them a phone number which our nurse carries 24/7, and she gets compensated for it. We pay extra amount for her to carry the phone and pick the calls in the night. And now we prefer a smartphone so that we also get videos from the families. I don't know the situation in Bangladesh, but in India, internet is very, very cheap. Everyone has internet. So they take videos and send videos, and they ask questions like, are they seizures or not? And over the phone, I can say if it is seizures or not, and if they have to treat it. So the phones are very helpful, and these are the incoming calls, and the outgoing calls are done based on the priority too. So we also call them at regular intervals to check how they're doing.
And if the nurse doesn't know the answer, then she would contact with you to get more support, right? Yeah, and you have trained palliative care nurses who've been doing this for many years. So at first, you probably need a medical officer to do this role as they get comfortable, and hopefully they've had some training in palliative care. At Center for Palliative Care, they have a phone that they pass between the medical officers, and they have a roster because it's a busier phone because they have so many patients. And we will post in the Google Drive one article about the telephone service of BSMMU Center for Palliative Care, because they've done some research on their palliative care telephone service and how helpful it is for the patients. There's a very good question here from Dr. Nadim, Mohammed Nadim Shahira, who says, do I need a separate place to break the bad news for parents, or may I do it in my daily ward round at the bedside with the patient? That's a very good question. And many times very challenging to find a separate place. So I want to hear from some of our participants about what have they done to solve this issue, because it's very easy to say, oh, you should have a separate place. It's very nice, but what can you do in reality when your hospital is very crowded and you don't have many quiet places? Any ideas? What are you doing, Dr. Janet? Are you having a separate room, or what do you do?
Thank you for the valuable question. Actually, in our limited area or availability, we don't actually still now we don't have any separate room that I have seen in Hyderabad MND Hospital, but we are trying our best. But in this limited resource, we tried our best to do this counseling session in our limited resource actually. in a separate corner or in a silent area. Sometimes we have a small space in the lab. We can, sometimes we call them and sitting with them. Actually, we still have to do in this way. And in some counseling session, we also done as we have one indoor palliative care ward. In that area, we also done this counseling session, but we don't actually, we cannot build this actually.
Yeah, maybe can you describe what they have in Hyderabad, Jenna, just so people can know, like, what is the setup on the oncology ward there?
In Hyderabad, that we have seen in 2019, that is really very cool and beautiful. Though in a small space, but they have a very neat and beautiful small room, most probably 200 square feet, and having one corner in a counseling center, another is a play corner for the baby, and there's a 2 or 3 chair for the parents for waiting, and one cupboard where all the files actually they stored there or collect there or preserve there. And they have a board, and where they all the everyday's work they just noted there, and all the home visit, all the doctors who will come, will go, all the referral who will go, all the routines actually noticed there actually. In this way they made this set up in this way in the Hyderabad, in the MNJ hospital, in child palliative. But most probably this is near the oncology unit, oncology, that is ward. Beside the oncology ward, that's this counseling room actually. Yeah.
And this is another picture of another counseling room at Nilafar Hospital in Hyderabad. It doesn't have to be anything very big, right? They're just, as long as you have a small space with some chairs, and it can be used for something else in other times. You don't have to have it just dedicated for your own purposes. But again, I think there's also the option, Dr. Spandana is saying about speaking quietly with the patient at the bedside or speaking quietly with the family at the bedside. I would not do it on your ward rounds. Ward rounds is like solve all your problems, figure out what the patient needs, medicines, change things. It's not the best time to do a lot of communication. Like ideally, if you can identify who needs the communication and then do it after the ward rounds when you don't feel like rushed to go to the next patient. That might be a better option. I see a question from Dr. Noor Jahan I'm going to read out as probably our last major point here. If parents are not convinced to tell the truth to their children regarding disease as well as prognosis, what will be the suitable approach to answer the child's questions if the child's an adolescent? This is very challenging. Good question, Dr. Noor Jahan. So I think Dr. Spandana had touched on this already, but maybe we'll let her give a few comments about how you do this.
Again, I think it depends on the question they are asking. If it is a simple question, when will I be able to go back to college? Even that is complicated sometimes. Or if they ask, am I going to get cured? Sometimes so there are different strategies I follow here. The first thing is I first let my nurse or social worker speak to them. And I tell them if there are any difficult questions, tell them you don't know and that you will talk to the doctor and get back to them. Right? So that the social worker doesn't have to do anything and I know the questions ahead of time. This is very cunning of me, but this has worked very, very well for me. So someone goes ahead and asks the question. But then not many of us will have social worker or nurse to do this conversation. And when I get the question, if it is related to cancer, I say, if it is very difficult and I don't have an answer, I'll say, let me check the case sheet or let me talk to the oncologist or let me once go back and look at your file and come back to you. And that time I use it to speak to the family. Right? This is a way of not escaping, but buying some time so that I can ask the family, your son or daughter has asked me a very specific question about the college thing. So what do you think? And again, it's the same thing where we are bargaining with them about how to best answer the question without lying. And I never lie. I probably will beat around the bush if I don't have to say. But yeah, these are the few things that that are on the top of my mind. Megan, over to you.
Thank you. So some good strategies there, I think. And you had mentioned that strategy before too, is like, if you know you haven't taken permission yet to say, you have to buy time, right? You have to say, I'm going to go check the file. I've got to go talk to the oncologist. Or you say something like, what do you think? Okay. And then if they say, I think that I'm not going back, I think it's not getting cured. I checked on Google after I saw the last biopsy and I see that it's not going to get better. Then you can just say, yeah, I think so too, right? Like they've already said it. So then you're not telling anything new. You will not improve the situation by telling somebody not to worry, right? I want to emphasize on this point. People do not feel better if you just tell them, don't worry about it. That is not therapeutic. We do not recommend that because it doesn't help. People do not worry less just because you tell them not to worry. They're worried because they're really sick and nobody's telling them anything. It doesn't help to just say, don't worry about it. So that would be what not to say. And then the other thing is to really emphasize to the parents that this will help. This will allow you to talk openly with your child. You will feel better. You know, we know that parents feel like there's a more open relationship. You can't support your child if you're lying to each other, if you're hiding something so big from your child. How can you really have an open communication and support your child in this most difficult time of their life emotionally? And you will, wouldn't you regret it if you couldn't actually show your child love and support properly because you wouldn't talk to them? And sometimes adolescents get very angry because they're not being told. And so sometimes we see that once finally somebody sits and gently talks with them, then they calm down a lot and they're much less angry. And you wouldn't want if you're a parent, you don't want your child angry with you as their last emotion before they die. So we emphasize on some of those points. But so many things to say that are really important here. And I think we'll continue these conversations during our next session, but I see we're at the end of our time. So I'll hand back over to Dr. Jana to wrap up, and really looking forward to more conversations about these interesting questions during our next sessions.
Thank you, Megan. Thank you all the faculties and participants for interactive discussion and question and answer session. It was actually a really enriched session. Thanks all. Now we are at the last part of the session, that is a short summary in Bangla. আজকের আলোচনার মূল বিষয় ছিল শিশু চিকিৎসায় কমিউনিকেশন অথবা যোগাযোগের গুরুত্ব। জীবন সীমিতকারী রোগে আক্রান্ত শিশুর প্যালিয়েটিভ চিকিৎসা দেবার ক্ষেত্রে যোগাযোগ বা কমিউনিকেশনের কোনো বিকল্প নেই। আজকে আমাদের এই আয়োজনে সম্মানিত দুজন বক্তা ডক্টর স্পন্দনা রায়লা এবং ডক্টর নীলুফার চৌধুরী অত্যন্ত সুন্দর সাবলীল সহজ ভাষায় বিশদভাবে বর্ণনা করেছেন এই বিষয়টি এবং বিশ্লেষণগুলো তুলে ধরেছেন। মূলত তিনটি বিষয় বিশেষভাবে আলোকিত হয়েছে: যোগাযোগের উপাদানগুলোর রূপরেখা, ইফেক্টিভ কমিউনিকেশন বা উন্নত যোগাযোগের ক্ষেত্রে সক্রিয় শ্রবণ দক্ষতার প্রয়োগ, ব্রেকিং ব্যাড নিউজ বা দুঃসংবাদ জানানোর জন্য কিছু বৈজ্ঞানিক পদ্ধতি যেমন স্পাইকস মডেলের প্রয়োগ। কমিউনিকেশন বা যোগাযোগ হচ্ছে একটি ত্রিমুখী প্রক্রিয়া, যেখানে জীবন সীমিতকারী রোগে আক্রান্ত শিশু এবং তার পরিবারকে তার রোগ এবং চিকিৎসা সম্বন্ধে অবহিত করা হয় এবং তাদের আবেগ প্রকাশে উৎসাহিত করা হয়। কার্যকরী যোগাযোগের ক্ষেত্রে, দ্যাট মিনস ইন ইফেক্টিভ কমিউনিকেশন, কথা বলার ভঙ্গি, দ্যাট ইজ বডি ল্যাঙ্গুয়েজ, এবং স্বরের প্রক্ষেপণ অনেক বেশি জরুরি। যোগাযোগের কৌশলগুলোর বেশিরভাগ উপাদানগুলি শেখানো যায় এবং এই শেখানোর দক্ষতার সাথে চিকিৎসকের ভালো যোগাযোগের ক্ষমতাতে এর প্রভাব পড়ে। একজন ক্যান্সার আক্রান্ত শিশু তার জীবন মৃত্যুর সন্ধিক্ষণে অনুধাবন করতে পারে, এটা তার সিক্স সেন্স। এবং মৃত্যু আসন্ন সে বুঝতে পারে। তাই তার মৃত্যু আসন্ন সময় দেখা যায় তার বাবা মা এবং ডক্টরদের অসাধারণ চাপ সে বুঝতে পারে। তাদের অসুস্থতা এবং আসন্ন মৃত্যুর বিষয়ে প্রকাশ করার অনুমতি না দেওয়া হলে তারা প্রচণ্ড বিষণ্ণতা এবং বিচ্ছিন্নতা বোধ করতে পারে। এই জন্য মৃত্যুর বিষয়টি শিশুদের সাথে আলোচনা করতে হবে। কোথা থেকে, কিভাবে, কেমন করে শুরু করতে হবে, কি কি ব্যাপারে বিশেষ খেয়াল রাখতে হবে, এই ব্যাপারে আমাদের দুজন বক্তাই বিশদ আলোচনা করেছেন। তাদের মধ্যে যেমন উল্লেখযোগ্য, বাচ্চারা বুঝতে পারে এমন শব্দ ব্যবহার করুন, ছবি আঁকুন বা খেলার মাধ্যমে বাচ্চাদের আবেগগুলো বোঝার চেষ্টা করুন। যে শব্দগুলো বিকাশগতভাবে উপযুক্ত তাই চয়ন করুন। একটা ব্যাখ্যা যদি যথেষ্ট না হয়, বাচ্চাকে আরো কিছু ব্যাখ্যা দিয়ে সেটা বোঝানোর চেষ্টা করুন। শিশুর উপযুক্ত ভাষা ব্যবহার করুন এবং তার আবেগ অথবা কোনো দৃশ্যমান প্রতিক্রিয়া যদি থাকে সেটা লক্ষ্য করুন। পরিশেষে জরুরি কিছু বিষয় সংক্ষিপ্তভাবে উঠে এসেছে আমাদের সম্মানিত প্রথম বক্তার বক্তৃতায়। যেমন উনি বলেছেন, আপনি যেভাবে পারেন ঠিক তেমন করেই করুন, আপনার সীমিত ক্ষমতার আদলে। শিশুদের সহায়তা করার ক্ষেত্রে একাধিক উপায় রয়েছে। আপনি যে জিনিসগুলোর সাথে সবচেয়ে বেশি স্বাচ্ছন্দ্য বোধ করেন সেভাবেই চয়ন করুন। স্বীকার করুন যে সবকিছু এই ছোট অল্প সময়ের মধ্যে ভালো করে নাও হতে পারে। শিশুরা তাদের বোঝার শব্দ ব্যবহার করে কথা বলবে, এই ব্যাপারটা আমাদেরকে লক্ষ্য রাখতে হবে। একেবারে বা প্রথমবার কিছু কিছু করে তথ্য দিন। বাচ্চাদের প্রশ্ন জিজ্ঞাসা করতে উৎসাহিত করুন, সত্য এবং সরলভাবে তাদের উত্তর দিন এবং পুরো ব্যাপারটাতে শিশু এবং তার পরিবারকে জড়িয়ে রাখুন। সাথে সাথে আপনার নিজেরও যত্ন নিন অথবা সেলফ কেয়ার করুন। আমাদের সম্মানিত দ্বিতীয় বক্তার তার প্রেজেন্টেশনে আমরা আরো কিছু গুরুত্বপূর্ণ তথ্য আমরা পেয়েছি। যেমন, যখন কোনো শিশু প্রাণঘাতী ক্যান্সারে আক্রান্ত হয় তখন তার বাবা মা অথবা অভিভাবককে শিশুটির রোগ নির্ণয় অত্যন্ত সহানুভূতির সাথে অবগত করতে হবে। দুঃসংবাদটি অভিভাবকদের জানানোর আগে কোনো কোনো বিষয় কখন কিভাবে বলবেন সেটা একটা খসড়া তৈরি করে ফেলা ভালো, এবং কিভাবে বলবেন সেটা আরেকবার পর্যালোচনা করে নেবেন নিজের মধ্যে। রোগ নির্ণয়টি অবগত করার সময় কিছু বিষয় মনে রাখা দরকার, যেটা সংক্ষেপে স্পাইক্সের মাধ্যমে আমরা খুব সহজে ধাপে ধাপে করতে পারি। যেমন স্পাইক্সে এস মিন্স সেট আপ। সবচেয়ে ভালো হয় যদি কোনো শান্ত পরিবেশে বা আলাদা ব্যক্তিগত কামরায় দুঃসংবাদটি জানানো হয়, সাথে প্যালিয়েটিভ কেয়ারের অন্যান্য সদস্যরা থাকলে ভালো হয়। পি ফর পারসেপশন, দ্যাট ইজ এই ধাপে শিশুটির অবস্থা, অসুস্থতা সম্পর্কে বাবা মা কি মনে করেন, কি ধারণা পোষণ করেন তা জানা অত্যন্ত গুরুত্বপূর্ণ এবং ধৈর্য ধরে আমাদের এটা শুনতে হবে। পরবর্তী পর্যায়ে, দ্যাট ইজ ইনভাইটেশন, আমরা অভিভাবকদের জিজ্ঞাসা করা জরুরি যে আমি কি আপনার সাথে যা জানেন তার সাথে কিছু যোগাযোগ করতে আর যোগ করতে পারি কিনা। দেন কে ফর নলেজ, এই পর্যায়ে তাদের বলতে হবে দুর্ভাগ্যজনকভাবেও আপনাদের কাছে এই দুঃসংবাদটা আমাদের দিতে হচ্ছে। আপনার শিশুর ক্যান্সার বা যে অসুখটা ধরা পড়েছে সেটা তাদেরকে ধীরে ধীরে বলতে হবে এবং তাদের চিকিৎসা সম্বন্ধে এই ব্যাপারে কি কি করা যেতে পারে সে সম্বন্ধে তাদেরকে বিস্তারিত বলতে হবে। ই ফর ইমোশন অর এমপ্যাথি, এই ব্যাপারটা খুবই গুরুত্বপূর্ণ। উপরে তথ্যগুলি দেওয়ার পর তারা মানসিকভাবে ভেঙে পড়তে পারে, এটাই স্বাভাবিক। তখন তাদের আবেগগুলো বোঝা, সম্মান করা, সহমর্মিতা প্রকাশ করা, আবেগগুলো সম্পর্কে আরো জানতে চাওয়া খুবই প্রয়োজনীয়। এবং সর্বশেষে এস ফর সামারিতে আমরা এইভাবেই ব্যাপারটাকে নিয়ে নিতে পারি যে পুরো ব্যাপারটা তারা বুঝেছে কিনা সেটা আবার রিভিউ করতে পারি, এবং কোনো প্রশ্ন আছে কিনা, শিশুর কেয়ার প্ল্যান নিয়ে তাদের কোনো ধরনের ভাবনা আরও কিছু যোগ করতে চায় কিনা এবং অন্যান্য ব্যাপারে বুঝে নিতে হবে। এবং আমরা তাদেরকে যে সবভাবে সাপোর্ট দিতে চাই আমাদের সমস্ত ক্ষমতা এবং আমাদের যা কিছু আছে সেই ব্যাপারটা তাদেরকে আমরা বোঝাতে সক্ষম। এই ছিল আমাদের বাংলা সামারি। আপনাদের কারো যদি কোনো প্রশ্ন থাকে করতে পারেন। Hello? Hello, am I audible?
Yes, you are, Papa. Actually, Megan is not here. If anybody doesn't have any question, it's over to you, Dr. Jannat. You can end the session now.
Now we are the last end of the session. Heartfelt gratitude to our honorable speakers, Dr. Spandana Rala and Dr. Nilufar Chaudhary, organizer of this program, and especially lovely participants from home and abroad for their patience hearing and their heart as because they're the heart of program. And very, very special thanks to Dr. Megan Doherty and our lovely madam, Professor Dohra Zamila Khan, for their strong leadership and initiative for this program. Next session will be in 16th July, Friday, in the same time from 7:30 p.m. Any query or any question, please write in WhatsApp group. We'll try our best. Stay safe and goodbye. Bye-bye.